It's such an honor to be here and to speak with all of you today. Thank you for coming. Today's topic I would like to talk about is improving laboratory utilization in ambulatory care and the role of physician feedback. The learning objectives at the end of the hour are to name 5 essential elements of a quality physician report card, explain 3 reasons why feedback works, and 3 reasons why leadership support is important for a successful program. Now, to put things in perspective, I want to tell you a little bit about our group practice. We're a regional practice. We cover the state of Washington and parts of northern Idaho. We have approximately 540,000 members, 350,000 of which live in Puget Sound. We're 25 primary care clinics, and 20 of those are in the Puget Sound area. Our medical staff are 800 members of all disciplines, and we have an electronic medical chart that's statewide. Our laboratory network is also statewide. We have 25 clinic laboratories, 20 of which are located in Puget Sound. The group health owned and operated laboratories in the Puget Sound area consist of a core laboratory, 2 hospital labs, and 20 clinic laboratories. We are networked by a single laboratory computer system which uploads all the data into the clinical workstation. And we have computerized order entry statewide, and we serve a very large family practice discipline. Now, in looking over a continuous quality process, when you're trying to improve an organization or a process, you usually go through 4 stages. You usually try to assess and define the process that you wish to improve, take your baseline measurements, then implement your improvement plan, and then go back and monitor and then repeat the cycle over and over again. What I'm going to talk about is the 5th step and the importance of feedback to your target audience, those folks who you would like to see improvement. To put this in context, for those who are entering the laboratory medicine discipline, on the history and national trends, the United States orders more laboratory tests than any other industrialized country. And this is from a 1996 summary that I pulled this figure from. And given that I read in the Seattle Times just 2 days ago saying that the United States spends the largest percentage of its gross national product on healthcare services, more than any other country in the world, I don't think that this figure has changed at all. Some of the practice patterns that make our ordering patterns unique compared to other countries include large numbers of orders in preoperative assessments and admission laboratories to when people are admitted to the hospitals. For those of you who trained probably in the early 80s, when I was in medical school, when we admitted a patient to the hospital, they automatically had a battery of 20 or 30 tests, no questions asked. If they had these tests done before at a hospital from which they're being transferred from, didn't matter, we did them all anyway. And I know that this has changed, but there are certain mindsets that get ingrained in the physician's psychology that just stay with them throughout their practice career. And this is the elements that we're trying to change. In reviewing tests, particularly on the federal level, experts would review medical charts and find out that for many tests there was no indications as to why the tests were ordered, and this became a national reimbursement issue. And so this is why laboratories today are just meticulous in making sure that a diagnosis code is connected with every test every time. Back in the bad old days, some laboratories, fee-for-service standalone laboratories, would add on tests without the doctor's knowledge. This, of course, is fraud, and it's quite illegal. It's not done now. And so this is why laboratories are very careful now to make sure that there is a doctor's order connected with every laboratory. And then, of course, the United States ordering patterns, we tend to order a lot of custom panels and chemistry panels. In a revenue-generating standalone laboratory, the more tests that you order, the more money you made. And one strategy they would to encourage customer loyalty is they would go out to a doctor and actually formulate their own custom Dr. Smith panel to maintain loyalty. And this is something that also encouraged more laboratory ordering. Drivers for increasing utilization also includes the fact that we have an aging population requiring more testing. We also have an educated population that is demanding more. We're in a day and age where our patients are now going on to the internet and they're getting sophisticated information about lab testing on the internet and asking their primary care providers about that. We're also serving retired doctors, retired engineers, a very sophisticated, highly educated patient population now. We're also serving medically complex patients that are treated by many doctors, and as a result, these doctors don't know what the other guy's been ordering, and they don't know what tests that the patients have already had. Duplication is a major problem. We also have busy doctors trying to save time, squeezing the most into a 10-minute appointment time. And so we are up against a mindset of getting all the data at one time at one visit. Now, how does our network experience stack up with the national history and what's been going on nationally? Our test volumes, when we started looking at this back in 2001, have been growing a steady 5% every year from about 1999 to 2001. But the kicker in this is that enrollment declined at the same time. So as a result, we're actually ordering more tests for fewer numbers of patients. We also did a benchmark studies that suggested that our Western Washington clinics were ordering more laboratories than our peer systems. That set us to wondering here. Here we have data from our benchmark. The 25th percentile there denotes the ideal practice or the desirable practice, and then the 75th percentile bar denotes the, quote, loosely practiced organization, and here we are right here. So we have some work to do. So what did we do? Well, we did what any organization would do. We formed a committee, and we locked ourselves into a room. And we said, well, what do we do? How can we improve our utilization? And we brainstormed, and we came up with these 9 strategies by which maybe we could get a grip on what's going on. So we decided that we were going to redesign our lab requisition, adhere to testing guidelines to healthy adults, develop a process for handling non-FDA approved tests, pre-authorizing high-cost tests, eliminate duplicate testing, evaluate ordering patterns for mid-level providers. Now, we got this one because our line techs were telling us out in our clinics that non-MDs, such as registered nurses and PAs, tend to order far more laboratory tests than the doctors do. And so this is an area that we wanted to explore to see if that was true and see if this was an opportunity. We also wanted to improve the system for reviewing standing orders and then improve order entry through a well-designed clinical information system. Now, at this particular time, the clinical information system hadn't been implemented yet. We were still on a paper laboratory requisition system. And the clinical information system was being rolled out and implemented system-wide at the same time that our utilization program started. So this made for some very interesting information. And then last but not least, we wanted to measure and compare physician practices through profiling. So the next part in our quality improvement project is we did a practice survey. We found out that, like I mentioned before, we're a largely outpatient practice. Roughly 60 to 70% of our tests are ordered by primary care physicians. We have evidence-based guidelines in place, so we didn't really feel that this was a problem. And then we did a survey of what our most commonly ordered tests were. And I was surprised to see that our commonly top 10 tests were the bread and butter tests, because we have primary care was ordering these tests. So it was the bread and butter tests, the everyday tests, such as the UAs, the CBCs, the chem panels, and the electrolytes. And then we did a little cursory chart survey where we looked at 75 charts and observed that many tests were ordered as part of a wellness exam. So this is a benchmark slide that I lifted from our analysis here. And here you can see that 98% of these tests are tests that we do ourselves. And this is out of 4 million reportable tests that we did in a year. our send-out tests are less than 3% of our testing volumes. And according to our benchmark surveys, they weren't that much of a problem even on a dollar scale too, even though that on a per cost, per test basis, they were more expensive. The real problem in reason and showing and why we're not benchmarking that well with our peer system is here. So then we did a more robust chart on it, a lot more thorough review. And this time what we did is that we had a survey tool that we handed out to chart reviewers. We organized formal chart reviews at 5 clinics. We recruited the primary care chiefs, and they also recruited their medical staff leads. We met at lunch, and we sat down at a table in a little room, and we just went through charts, and we filled out our survey tools. And at the end of the hour, we just put our papers into a little basket, and then we added them all up. So in our audit filings of 255 charts, we found that 28% of tests were ordered as part of a periodic health assessment. 21% of the tests, as mentioned before, did not link to any clinical investigation. 15% of recurring tests were ordered at an inappropriate interval, and I'm talking about perhaps lipid panels that are ordered like 4 times a year instead of once a year. A1Cs that were ordered monthly instead of maybe every couple of months or so. So we had some problems here in how recurring tests were being ordered. And then 18% of panel tests were ordered in situations where a more specific test would have been sufficient. Now, this is not old information. This is not rocket science. This has been known for 20 years. This individual, Tommy Thompson here, published in Preventative Medicine the very same thing of our healthcare system back in 1983. And it's been validated again by Dr. Reed in an unpublished survey that he did over the same time period that we did our chart review. And in his unpublished study, he found that 25% of all outpatient visits are for a periodic health exam. So I think this matches very nicely. So let's back up a little bit. What are the recommended health exams? What should people be getting as part of a health maintenance well adult exam? Well, as you can see here from the list, it's not very many tests. In fact, it's hardly anything. And these are the group health recommendations for wellness exams. What's not recommended is routine CBCs, chem panels, TSHs, and urinalysis. Now, I also did a literature review and found that the U.S. Public Health Service Task Force and the American Academy of Family Practice, who have posted guidelines on laboratory tests and what's appropriate for periodic health exams, do not recommend these laboratories either. And in fact, our guidelines match up very well with what they recommend as well. So there's close agreement here. And this issue has actually made it into the popular press. And I clipped out here, included a web link here of an article in the LA Times talking to people about, well, if you go into the doctor for wellness exams, what should you expect? It's not the traditional executive physicals like you used to get anymore. It's different now. So here's what we did. We started talking about, gee, we seem to have a problem with our outpatient utilization. And then immediately, somehow, test volumes started to fall. That's all we did. We just started talking about it. And there's a certain psychology to this, I think. We changed our lab requisition. I went through the lab requisition line by line, and I probably eliminated about 40% of the tests. The other thing, too, I did with the lab requisition is that I grouped the important tests up in the upper left-hand corner because you read from left to right before you start going down the page. So the wellness tests were grouped up here. And then I tried to group the tests that you would use logically to work up certain disease categories. So I grouped the diabetes test together, the obstetric test together, the cardiovascular test together in a way that made sense, so that people would only order what's necessary for the most common clinical conditions. And then if there was a test that the clinician wanted that wasn't listed on the list, he could write it down on a little blank square right here in the lower right-hand corner. So he had to work to get the test. And I wanted to get this test requisition out before the electronic order entry platform was put in place, because I wanted to encourage good ordering practices before the clinician got in front of the keyboard. So we changed our requisition, and test volumes fell by 10%. Well, we were pretty happy with that. But then the next step we did is we published the provider report card. And this is what's made our progress sustainable. Test volumes have remained flat, with the exception for a 2004 bump. And that wasn't because there was a fundamental change in test ordering practices. That was because there was a new initiative that took effect that increased lab ordering. So in surveying lab utilization literature, the one thing that I find missing is the feedback piece and the sustainability of their changes. And so this is what I'm presenting to you today, just to show you how the report card can make your changes sustainable. The report card is key to this program, but to have a good report card, it has to have certain key elements. You have to have a focused message. It must be timely. You can't just issue this report card once and think people's going to remember this forever and ever. You have to keep reminding folks about good laboratory practice. It has to be a meaningful number that's meaningful to the practice at hand. So I can't have specialist, data for a person who's practicing family practice. It's not going to have any relevance to them. It has to be, somehow they have to be able to connect with this. You have to set expectations, which means you have to designate and define targets. And this has to be an unmasked report. The person looking at the report has to be able to compare their practice patterns with that of their colleagues who are practicing at the same clinic. So obtaining the data. This is where we brought in the experts. We brought in an analyst to help us with this. And we also brought in 2 doctors who are very familiar with laboratory utilization and who helped us negotiate and through the coding quagmires through this. But in attaining the data, there's certain principles that I have learned along the way. Just going through your LIS and coming up with a simple test count is not enough, and it's not relevant. Just going to the medical staff saying, oh, gee, guys, you're ordering too many CBCs, please stop, it's not going to work. They'll just look at you and just say, so? The test must relate to the diagnosis, and this is why this data is hard to get. You have to go into a data warehouse and be able to get the data where the test is actually connected with a diagnosis. So you also have to have accurate collection of this data, and you have to have accurate coding. The data has to account for changes in the number of patients or enrollment size, and it has to correct for practice intensity. So thereby, you sidestep the whole argument of I see more patients, thereby I order more tests. Point number 2 sidesteps the argument, well, I order more tests because my patients are sicker. Well, you have a common denominator that gets around that argument. Definitions have to be precise. Who's the ordering doctor? What are the tests? And you have to pay attention to how the data is captured. So in making sure that we have all our ducks in a row and coming up with our practice report, we had to come up with a template tool. And this is the tool that our analysts used in helping us develop the report. We had our essential data elements that we want on the report, the definition of what the UN committee was after, our data source, and any kind of barriers or issues that we had to work around to either get the data or decide not to even include it onto the report. So we grouped the data by service center, practice specialty, ordering provider, and the number of tests, and then number of the tests per visits, number of well visits, and we use the V codes here for the well visits. And then we looked at the target tests that we want to decrease utilization on, and we looked at the what we call the KIM 14. This is the comprehensive metabolic panel. It has 14 tests in here. So this is the test that we targeted for the well visit data, the CBCs, and then the TSH. So in obtaining the data, it took us a couple of months to come up with our template. So, and then after that, we then went to the data warehouse to get the data to see what it is we had. So we did our dry run, and then we made corrections. I mean, we were getting people who didn't order very many tests, and in that case, then we had to drop them off the list because they weren't relevant. For example, the pediatricians. The pediatricians don't order hardly any tests, and so they were dropped off the list. We didn't want to include the obstetricians, and a few of them snuck in there, so we had to get them off the list too. We were targeting family practice. And so after we made corrections, we did a second dry run and noodled with that a little more until we had a report card that we felt was ready to present to our leaders. And that took us about 3 months to go through this process of coming up with a report card. So the next step in presenting to the leaders is that you need to get their feedback. Is this information you can use? What else do you want? Leadership buy-in. The next key to a successful program. You have to convince your leaders that utilization is important, because if you're going to be circulating a report that has names on there and names of physicians and suggesting that perhaps there are things that they need to do to improve their practice patterns, leadership buy-in is essential. Leadership buy-in is also essential because you need resource commitment. The analyst had about 40,000 other projects that people were asking him to do. And to get this person to put our project from the bottom of the pile and have it move up to the top required support from the leaders. You're going to ask your leaders for their public support, and then the last but not least, you're going to ask your leaders to hold the reports accountable. So this is where you can get traction in your program and get your audience to pay attention to what it is you're trying to tell them. So, when I first entered pathology practices, I did not want to have anything to do with org chart. But now that I'm the head of a laboratory, I am one pathologist, and there are like 800 docs out there. And so how in the world am I going to get my message out there and get them to listen to me? The org chart became my friend, because the org chart affects, my little report is going to go out to 217 providers. So I had to convince the head of the health plan, the delivery system medical director, Puget Sound director, primary care director, and all of these guys down here, that this is a worthwhile project to do. And that took about the better part of the year to do that. I went to about 13 committees, did about 15 presentations, and presented to all of these different groups. Now, this was important. I mean, you have your official leaders here, but down here in these working committees, you have the unofficial or the shadow organizations, and these are the opinion leaders that the docs in the trenches look up to. And if you could convince them that your project is worthwhile, then the other docs who see the patients every day will look up to them and they'll buy into this. So actually, this is time well invested and well spent, though I burned a lot of miles on my car. So anyway, so in making the case, you need to convince your leaders that our utilization is too high and that it drives non-productive utilization of other services, and it adds to inefficient lab services. And nobody wants an inefficient lab. We can't really tolerate that. Now, another tip in talking to leaders, these are very busy people. They're very bright people. I could talk to you and have 45 slides. With them, you have 10 minutes at most to make your case. And that really boils down to maybe 5 slides. And so you have to be on the mark, and you have to make sure that you get the point across in as few minutes as possible. Then allow them 5 minutes to ask questions. So here's the example of our report card. I had to trim it down because I couldn't get all the information on the screen. But this is the meat of the essential elements of the report card. This is an actual report card that we have sent out a quarter to a mystery clinic up here. These are our targets that we have defined for the ordering levels of the Chem 14, CBC, and the TSHs. Now, these are tests per 100 well visits. And so you have a listing of well visits in one column, and then the number of tests, number per 100 well visits listed down here. And then down here, you have the clinic average, and then it's rolled up into the organizational average. So as you can see with these 5 docs here, all of these docs, they know who they are. They work with them every day. They even know how many patients they see, and they know how their ordering patterns are. So, for example, docs who are outliers or docs who exceed our target measures are highlighted in blue on the reports. So as you can see, Dr. C is highlighted for the high numbers of CBCs and TSHs that this individual orders. But he could look down at Dr. C and say, hey, this guy sees more well patients than I do, and he doesn't order as much as I do. So we were hoping that when we issued the report, that peer pressure would have an effect on our group, that somehow there was a herd mentality, that nobody wants to be different. And so we were relying on that for our first year when we did this report. So the very first report was published in the first quarter of 2003, personalized report. And most practitioners discontinued ordering all 3 labs entirely. And there was no adverse outcome whatsoever, none. I haven't heard a thing. And risk management hasn't contacted me, nothing, you know. And then 83% of the medical staff, I'm taking Chem 14s for an example, because I am convinced that this is absolutely the one test that shouldn't even be on the menu, anywhere. So 83% of our medical staff don't order this test at all. And our wellness testing measures continue to drop. This is amazing. It's better than I thought. Now, a word on setting the targets. Okay, you're coming up with a physician report card. You're dealing with a fairly demanding and critical audience. After all, you know, they have scientific training, and you do too. There's no national benchmark for this. I mean, there's no national society that says, you know, you shouldn't order X number of CBCs per 100 well visits. It's just not out there. But we do have benchmarks or societies that are saying, you know, you shouldn't order these tests at all as part of a wellness visit. We do have that. So what we did is that we waited a year, and then we looked at our trends, and then we set the targets. And so in the first year, what I decided to do is that a reasonable, achievable goal would be to decrease the CBCs and the TSHs by half. I figured that was a good place to start. And because I feel so strongly about the comprehensive metabolic panel, I set that at 0. They shouldn't be ordering this at all. And then after about 2 years of data, we tweaked it. And this is what happened. These are our trends. This is where we started in 2003, and this is where we are now. And isn't that just great? These green lines here are the CBCs, and then these yellow bars here is the TSH, and these little purple bars here is the Chem 14s. So we had, it's almost like weight loss. You know, you first go on the diet, you lose weight really fast at first, and then things kind of start slowing down here. And so I was concerned about here. Are we really making progress now, considering where we were in 2004 and 2005? So I did a little analysis where I compared the two quarters here, and yes, we have. We've made quite a bit of progress. In fact, I was hoping, and I would have been happy with just a modest 5% decrease. But as you can see here, we decreased the testing measures far more than that. So this looked good. And looking at our practice trend a little bit more closely, particularly with the Chem 14s, we started out with an organizational average of 3 Chem 14s per 100 well visits, and we dropped it by 1/3. And then the number of docs that we circulated our report to was 268, and that has been pared down to about 217 for various reasons. And this is what I find interesting, is that the percentage of docs who were at target, who didn't order the Chem 14 at all, was 84% when we started, and it's at 83% now. So this has pretty much been relatively the same. But look at this. This is what has changed. We had outlier docs that ordered more, and I define that as an individual ordering more than 10 tests per 100 well visits, or more than 10% of the time. We had 22 outlier docs here in 2003, and today we have 6. And I haven't done anything personal. I just been putting out the report and putting out summary reports once a quarter. But are we really making progress? Have we really seen change? Well, I mean, the data that we've seen so far is that we see overall decrease in the wellness measures, but our Chem 14 target organizationally, we're not there yet. I mean, we're still hovering around at 1, and we've been there for quite a while. So the next question our committee asked about a month or 2 ago is, are clinics really making progress? I mean, are the clinic chiefs truly presenting this data to their docs? Are they seeing this? And are they truly making efforts to improve their practice? So we did a trend analysis. What we did is that we took every clinic, and then we tracked them from 2003 to present, and looked at their trends, their ordering trends over the 3-year period of time. At the same time, because you could track your clinics, you can also track any doctor that you're interested in too. And so the committee looked at this trending data. They selected 5 clinics that they felt could have used some, a little improvement, a little nudging. And so what we did is that we took our 5 target clinics, and in addition to the usual summation and the quarterly report card, I also submitted to them a trend analysis and saying, look guys, you're kind of above the desirable threshold. Let's see what you could do to kind of get this down a little bit further. And this went to the chief, and this also went to the superiors. So here's a summary of our little trend report. In third quarter, this is where we were at in our 5 target clinics before the report. And here's where they are now in the next report after the trend analysis. So the first 3 clinics here made what I felt good progress. It looked to me like they acted on the information that I gave them. This clinic down here had a fairly low levels of ordering, so I'm not too concerned about Clinic 4. But look what happened with Clinic 5. That was kind of a mystery and I guess a situation where I was a little dismayed. They actually went up, and I couldn't figure out why. So we needed to look at that a little bit more closely. So here is clinic number 1, who had a fairly substantial decrease on our little trend report. This is a large 17-doc clinic, and here's their trend report. And as you can see, they're going steadily upwards, not where I want them to be. And so this is an excerpt of the actual comparison between third quarter and fourth quarter. Of these 17 docs in this clinic, 12 were already at target. So we're only talking about a handful of docs. Their average went from 3 down to 2 between third and fourth quarter. But look at these 2 docs here. This guy here went from 15 to 5, and this one went from 7 to 1. So that seems to be, somebody seems to be paying attention there. I find that encouraging. Here's another clinic that we were concerned about. This is a smaller clinic, but as you can see, their trend line is basically flat. And so, being that we've been, putting out this report for about 3 years, I'm sitting there thinking, well, why are they flat? Are these guys actually looking at the report, or is it going into the wastebasket? So I did a deeper dive on this clinic. This clinic is a little smaller. It only has 10 physicians. They decreased from 3 to 2 after my little trend report went out. This guy down here, doctor number 9, is the outlier doc of 30, and he went down to 24. But look at this here. This doctor in number 1 wasn't here in third quarter, and suddenly this person appears in fourth quarter and starts ordering all these tests. So what this tells me is that I don't think the word is getting out to the locums guys, the guys who cover other doctors when they're on vacation. So this gives me a hint that maybe we need to put a message out to the locums. And here's our last clinic, the clinic that actually went up. And as you can see, their trend line was actually going down, and they were making great progress. I mean, look where they started. They were up at 5. And they were coming down very steadily. And geez, what happened? Well, again, it looks to me, in third quarter, we had a physician who wasn't here, and then suddenly they appear in fourth quarter, and look what happened. They're ordering, chem panels on 30% of their well visits. It's like, man, somebody ought to slip the word to this guy. But then look at this. This is very interesting. You have a doctor here who's at target, and then boom, he jumps up to 12. You got somebody down here with a low level of ordering, and then boom, a sudden decrease up to 12. Well, it turns out this clinic was the last clinic to go live with the clinical information system. And I think what's happening here, in the dynamics here, is that we have a couple of docs who are having problems ordering their tests. And I've heard this before. There have been some other group meetings. Doctors don't like to toggle back and forth between screens, and I had to enter these orders myself before we went live. And on some orders, yes, you have to toggle between like 3 screens just to place an order for one test. And I had one doctor actually tell me, well, Kim, it's just easier for me just to order the panel and just get it all done with. So that's what I do. He says, I normally don't like to do that because, all I had to do was just check the blocks. but it's just faster for me to order the panel than trying to order through individual tests. Well, on some of the clinics, we actually looked at that, and usually we see a little bump like this, but then after a period of time when the docs kind of get the hang of working the keyboard and the mouse and all of that stuff, these tend to simmer down, because I think these two guys, they probably know better. They probably are feeling guilty. So I'm going to give them a little bit more time before I start sending them letters. So after all of this work and all the experts, did utilization did our project on our wellness campaign have any effect on our overall utilization? Well, these are what our trend rates are now at present. As I mentioned before, we're a statewide system, so statewide we're holding our trend to less than a 4% increase. If you read the news and follow healthcare costs, pharmaceuticals are increasing between 8 to 10% a year. So I think if we can hold our trends to less than 4%, we're making really good progress in trying to keep utilization and hopefully our costs under control. And here's the Puget Sound figure. It's basically flat, pretty much the same as what it was last year. And we were started out growing at a steady 5% a year. So I think this is a real achievement. And contrast it here with what's going on in Central Washington. Now, Central Washington is made up of our 5 owned clinics, but that's a small part. The rest of it is a network healthcare delivery system where we go out and we contract family practice groups and specialists to take care of our patients. And this is a little bit closer to a fee-for-service setting than what we are here in Puget Sound. So it's a little bit different. And we don't have any utilization program at work right now in Central Washington. And their train rates have been bouncing around between 8 and 10%. But a caveat I want to leave you is that although their trend rates are higher than ours, the absolute numbers of tests that we actually order overall, if you total them all up, is still higher. At Puget Sound, we order at about 5 to 3 ratio, and so therefore utilization here at Puget Sound drives the statewide number. So in conclusion, I want to hopefully I've illustrated to you that feedback really works. We were able to sustain a decrease and keep it down for like 3 years. The challenge, however, is to still keep it down, and hopefully our physicians won't regress. The individual provider practices have changed, and I was able to show you a couple of examples where I believe that some providers actually did change their practice in ordering fewer tests. The power of the report card is that you can see changes in the outlier practice. Our overall test trends have decreased, and I think it's because our quarterly reminders have promoted a greater overall awareness. And so that when the family practice docs actually see really sick people, like their diabetics, like their congestive heart failure patients, or their elderly, frail elderly, they tend, hopefully this kind of keeps reminding them and promote a greater awareness not to order too many tests on the sick population as well. And the power of this tool is that you can drill down and you can identify the outliers and you know who they are and where they are. But the essential elements of this program is that you need leadership support, expert input, medical staff input, analyst resources, and of course quality reports. Because, like I said, you're dealing with a demanding, well-educated audience, and they'll accept nothing less. And the quality report has to have the right metrics. It has to be timely, consistent, objective, and unmasked. And that's to make your job easier. You want the data to speak for itself. And so to wind this up, I'd like to thank all the experts who have helped me with this project. They're all listed here. And then for you to take home for interest in case you want to pursue a literature search or delve a little deeper into lab utilization matters, I've included 4 references that I felt were very useful. So I want to thank you very much for your time and attention, and I'm open for questions. Thank you.
I have a couple of questions. One is with regard to the first statistics that you gave as a number per test, that in this country we are ordering the most. I was wondering if this is per capita or is just looking at the number of tests that are ordered in the United States.
I don't recall because this was an old paper, and it could have been per capita, but I'm not exactly sure.
Okay. And the second question I have is that the interesting data that you presented, have you looked at, instead of looking at Dr. ABC, looking at the overall patient based on age and the basically categorizing patients instead of looking at a specific doctor? In other words, some doctors who are seeing people below 30, they may not order as many tests as those who see older populations.
Okay, well, I tried to correct for that because what I tried to explain to the providers that these are well people who come into the office with no complaints, you see. And so in the situation where a patient walks in and says, oh, by the way, doc, I have this pain, or I've been feeling tired, I say you should code those patients differently. You should code them for fatigue, you should code them for something else, you should code them for the complaint that they have, but don't code them as a well visit. And the docs come back and they say, well, you know, occasionally I will slip by and, you know, I'll just code them as a well visit because it's convenient. And my comeback to them is saying, I don't know the difference. All I know is the information you give to me. And if you tell me that patient's well, I'll take your word for it that they're truly well.
I enjoyed your talk quite a bit, Mike Astian from Lab Medicine. My question is, sort of what are your plans for the future if you're going to try, obviously this was aimed at wellness visits, and I was interested if you are planning on trying some diagnostic codes and utilization related to other, insurance codes.
Well, the reason why I haven't entered into that area is, as you know, there's a huge national push on HEDIS measures, and healthcare organizations are being evaluated on how well, their quality is being evaluated on how well they manage certain patient populations already. I mean, for example, screening sexually active young women for chlamydia and their screening rates for this, following their A1C levels for diabetic care, and a whole host of other measures. And so there's already a commitment of resources in looking at these particular diagnostic groups, and it's true in our organization as well. And so this is why I stayed away from those areas, because diagnostic testing in those areas are fairly well defined. They're posted on they're posted on our website, and we have a guidelines website, and so they're already posted there. Insofar as where we plan to go next, and here's what I've been thinking, and I have no data to back this up, but I'm working on this. A couple of things that I haven't seen in the literature, another driver of laboratory utilization, my hypothesis, is drugs. Anytime you put a patient on a drug, you need a test to follow them. And when I was entering all the standing orders, which is a huge headache in our system, it's a real operational nightmare. The vast majority of the standing orders that I hand transferred into the clinical information system was for medication monitoring. And so it begs the question. For example, let's go back to the TSHs. Right now we have an initiative going on with pharmacy that we're looking, are we ordering too many TSHs? What part of the TSHs are ordered just as part of a wellness screen versus those that are ordered for actual medication management? And for that patient population that's being monitored for medication management, are they ordering too many of them? Because right now we have a quasi, it's not really evidence-based because the evidence isn't there. It's expert opinion. But our recommendation is that if you have a patient on thyroid replacement and they're stable, you only need a TSH to monitor them once a year. And what I'm after are those docs who are ordering this more often than that, say, 3 times a year, 4 times a year, once a week, This is what I'm after. So this is one area that I would like to explore further, is medications. The other angle on this is that the Clinical Practice and Improvement Group, particularly Dr. Reed in his unpublished paper, thinks that, yeah, he thinks we're ordering too many TSH tests as part of the wellness guideline too. We don't really have an internal recommendation of when it ought to be ordered. And that's because there are societies out there. It's like PSA. There are societies out there with conflicting recommendations on screening. And so I think this is one area that we need to grapple with. But the next, I think the final frontier in laboratory utilization, why this is such a hard sell to administrators, is that the first question when you go to a medical leader who's in charge of like a multi-million-dollar budget, the first question they'll ask you is this going to save me money? The answer is no, it's not going to save you a whole lot of money. It's good because it drives efficiency. But the thing is if you're being benchmarked with other peer organizations and they're practicing better than you do, your purchasers are going to notice. And so that's one thing that you could use as a lever. But the other thing that I would like CP&I to do is that say for every nominally abnormal TSH, how many extra costs are then associated with that lab test. And what I'm after is the follow-up labs, extra phone calls, follow-up visits, referrals to the endocrinologist. This is where I want to see in hard data, and I haven't seen it in the literature, of saying, yeah, a false positive leads to increased service costs in the system as a whole. And by the time you get through following up, that false positive, say potassium or whatever it is, you've already, this 20-cent test may cost you in the long run a couple of $1,000s. And that will get their attention, particularly if you're talking about a false positive rate in a healthy population of maybe 20% with some of these tests. It's not unreasonable. So, any other questions?
Again, Kim, a terrific talk. Nice
Thank
to
you.
see you again and also hear about this. Have you thought about looking at specialists and what to do about kind of a different kind of practice? And I'm partly thinking about UWMC, where we have a rather small proportion of primary care practitioners compared with a large number of specialists, and whether this kind of peer feedback is likely to be helpful, and if you have some experience along those lines.
We've talked about it. And we've talked about it by looking at our send-out menu and whether or not we can go to our specialists and give them a report card of what we're sending out once a year. For example, Dr. Ashton and I were talking about the neurologic tests. We send out to Athena too, and our bill is also going up. But it hasn't been able to get anywhere, and it's mainly because there's just a few of us that are doing this. But yeah, that's the next step where we need to go, is to start counseling our specialists. But you see, it's another interesting point that you bring up here, because here we go. There it is. In doing your assessment as to where your utilization problem is, you need to target this carefully to make sure, or else you're not going to succeed. For example, if I issue blanket edicts to the medical staff saying you've got to get your Chem 14s down when 83% of them are already compliant, well, those are the folks that you're going to alienate. And you don't want to do that. You want to target this very carefully. And here in Central Washington, I think that's our problem. I think we have a problem there in specialist ordering. I don't think it's family practice, because the family practice doc in Spokane have lower levels than our family practice docs. In fact, once I get that data cleaned up and ready to present, I hope to leverage that against the Puget Sound system and say, hey, look what your brothers are doing across the state. They're doing better than you are. And docs are competitive by nature, and of course they want to catch up and be better than the next guy. But here we've actually looked at the referral rates in Central Washington are also up. And when we look at the numbers of tests that are ordered by the oncologists or some of the other specialists and compare that to our internal specialists, then we see a difference. And I think here, the specialists here are ordering more than our specialists over here. And so, yes, I think it's definitely a worthwhile area to look at. And in fact, that's what I think we'll probably be doing there, to try to get that trend under control. Yeah, thanks.